Thank you very much, and I'd like to thank the organising committee for inviting me to this session, which looks really interesting. I can't really talk about the whole of the role of MRI in rectal cancer in 20 minutes, so I've just picked a few areas that I think are possibly of interest to the group here. And one is using imaging to find the patients who are most at risk of local recurrence. If you're doing MRI in your institution, you will be familiar with images such as this, whereby you see the tumor which is extending right anteriorly towards the mesorectal margin. So that means that if the surgeon had operated on this straight away, they would have ended up having a positive margin, and then the patient would have got a local recurrence. And using preoperative chemo and chemoradiotherapy, as this patient had received, we can see that the tumor had regressed back to within the wall. And in fact, all of this tumor that we see here became fibrotic. And in fact, at the end of it all, this patient had a complete response. This is probably the best possible outcome, and it virtually negates the risk of the patient ever having a local recurrence. So really, the idea with imaging is to identify such patients and to prevent those adverse features from actually resulting in poor outcome. So when we analyzed the Mercury data, which was a prospective study enrolling patients consecutively and looking at their outcomes and using the MR assessment as part of sort of multivariate analysis, what we found was that of all the things that we could look at in terms of the clinical factors, as well as other staging factors, the MRCRM, which is the tumor distance within 1 millimeter of the mesorectal fascia, was the single most important predictor for local recurrence. And you can notice here that the difference between stage 2 and stage 3 really didn't bear any importance in terms of the patient's risk of local recurrence. In other words, there's no real evidence that lymph nodes per se are a risk factor for pelvic recurrence, and therefore shouldn't drive the preoperative treatment strategies for preventing that happening. The other important risk factor for local recurrence is the surgical plane. And in patients with low rectal cancer, tumor extending into the intersphincteric plane at the top of the anal canal is a particular risk factor, because TME surgeons will generally follow the mesorectal fascial plane, which takes them naturally to the surface of the levator and into this space here, the top of the intersphincteric plane. And this is where you can end up with the surgeon inadvertently perforating tumor. So what the role of imaging here is that this may be a perfectly safe operation if the tumor is not doing this at this point. If the tumor is slightly higher up, or if it's confined to the rectal wall, then it's perfectly okay for the surgeon to carry on and do a TME plane operation. But in a proportion of patients, this is not the case. And we noticed, and I think Phil Quirk did the most work on this, he noticed this problem of the surgical waste occurring, and this being the site of tumor perforation. So the MRI classification will enable us to separate out those patients in whom it's perfectly okay for the surgeon to come down this plane, and those patients where the tumor is extending into that intersphincteric plane, and therefore a more radical operation needs to be done. And so we came up with this staging system which enables those patients to be separated out. So stage 3 and stage 4, so tumor extending into the intersphincteric plane or beyond, would require a more radical operation. And in those reports, we actually state very, very clearly that in order to get a clear margin, this patient will need an extra levator APE. By saying that, you're actually helping the surgeon not to define the surgery during the operation, but ahead of the operation, and therefore prevent these inadvertent perforations from occurring. So when we analysed this, and this was the Mercury 2 study, which we've just published in the Annals of Surgery, what we found was that about half the patients with low rectal cancers, with tumours arising less than 6 centimetres from the anal verge, did in fact have a safe low rectal plane for TME surgery. And those patients who, if they went straight to surgery, their risk of a CRM involvement was less than 2%. So there isn't really a need for a blanket approach of preoperative radiotherapy for all low rectal cancers, as long as you stage them. But in fact, if you then irradiate those patients, some of those patients inadvertently got additional radiation, there was actually a numerically higher CRM involvement. And that was because possibly the radiotherapy made the surgery more difficult and made it more difficult for the surgeon to get a clear margin. So this is really the main finding from that study. And the other finding is that there are other things that are at play in terms of risk for margin involvement. The tumor height of less than 4 centimeters, the anterior border invading on the MRI, and MRI EMVI. And when you add them all together, if all 4 are present, there's almost a 50% risk of margin involvement. But if only 1 or 2 of those features are present, the risk becomes much less. And if none of those risk factors are present, then you've only got a 2% risk of margin involvement. So there are other factors, as you can see from that analysis, that we can evaluate different methods of tumor recurrence. There are obviously spread into neighboring structures. We've seen examples of that. Mesorectal fascia, adjacent organs. Lymph nodes, well, we think that they're probably the least important mechanism for pelvic recurrence, and probably in themselves aren't the method for patients developing local recurrence. But tumors spread via the blood vessels, yes, that is a method for local recurrence, and extramural vascular invasion is a significant risk factor. So here we've got examples on MRI of tumor growing into vessels that we see on the imaging, and it does correlate with when the pathologist samples the same areas, you will see the same phenomenon. Now, what we have a problem is that because pathologists are judged mostly on how many lymph nodes they find, even if they do notice this tumor spread into vessels, they may not always document it. And I think that's one of the big problems that we have to address, because when you look at the outcomes for these patients, they don't do well at all. And what we found with the MRI EMVI assessment is that it's present in about 30 to 40% of patients we're staging. And when we see it on the MRI, it's associated with a 30% disease-free survival at 3 years. So that means 70% of these patients are developing some sort of either local recurrence or distant metastatic disease. And the thing about it is that we see it at baseline, and we also know that when we restage these patients and perhaps see that this feature disappears, that also appears to be a good prognostic feature. So if you have persistent vascular invasion, as in this case, so here we've got the tumor at the baseline, and at the end of it, it's still involving the vein, that's bad. But when it's gone away, it seems to be a good prognostic feature. And when we looked at the post-treatment assessment of vascular invasion, both on imaging and pathology, and we've also looked at other factors such as the pathology nodal status, T-stage, CRM, and so on. What we find is that of all the variables, including pathological nodal stage, once again, it's only vascular invasion and CRM status that is predicting for poor disease-free survival. And on MRI, that is also an independent factor for disease-free survival. Now, one of the things you'll notice here is that the pathologist has picked up 46 patients with persistent EMVI, and the radiologist has picked up 99. So that's almost twice as many. And the hazard ratio is pretty much the same. In other words, we do see evidence that the pathologists are missing half the cases of persistent EMVI that we document. And this is what we published. We published these findings in the Annals of Surgery, and it did in fact show that if EMVI at the end of treatment is negative, i.e. it's gone from positive to negative, the disease-free survival is quite respectable. It's about 79%. Whereas if it remains positive, it's really poor, 42%. So, and pathology, it's a similar separation. It's just that they're mixing in some of these positive patients here in the negative group, and so their survival is not quite as good as the MR negative EMVI patients. What's also interesting is if you go from positive to negative, you get this improvement in survival. That was statistically significant. So you get a conversion effect, which lessens your risk of distant failure. So it's a treatment, it's something that's worth treating, and it's worth treating and changing status from positive to negative. The other thing about it is that when you look at these patients, you find a high rate of synchronous metastases. And by that I mean metastatic disease emerging within the first year, and also a high rate of metastatic disease, for example, detectable on PET-CT. So in this group, where we looked at a whole cohort of patients who were staged using MRI and then had an initial PET-CT, the patients without EMVI and with low-risk features only had a 5% rate of metastatic disease, whereas the group with EMVI positive disease had a 20% synchronous metastatic rate. So the next sort of area that is of interest is reassessing. So we've focused on MR-EMVI status and the importance of reassessing that. But how do we really judge whether a patient's had a good response or not? And traditionally, we've relied very much on the pathologist, and the only sort of definition that people accept as a good response has been pathological complete response. That's been a definition used as a marker for success in trials where you want to investigate a new treatment. But the problem with using PathCR is it's actually a very infrequent finding, and the more advanced cancers you get, the more infrequent it is. And maybe it's not the destination. Maybe we don't need to get PathCR. A good response is good enough. Conversion of EMVI positive to negative is good enough. And also, if you haven't staged these patients properly and you're treating a whole bunch of early rectal cancers, they probably were going to survive well anyway, and turning those into PathCRs hasn't really changed their outcomes, and it's probably introduced some additional morbidity. So the other thing about assessing response is it's very important to document the extent of the baseline, but also we are observing, and we're running a trial to document formally the extent of this, is that there is ongoing regression of the tumour beyond the initial 6 weeks that we tend to operate on these patients. And it's variable, and in some patients it can continue on a serial examination for a long time, up to 6 months after the initial chemoradiation has finished. So in other words, you take a gold standard at a point in time, you take a biopsy at a point in time, that may not reflect the ultimate tumour destination. It may actually be going forward to a lesser tumour, and there may be ongoing regression. So Stanley Yu, who was the research fellow at the Royal Marsden and part of the team, had looked at the predictive factors for tumour regression. And what we found in this group of patients, we looked at the baseline characteristics of tumour. And these were all patients with pretty advanced tumours. Our policy at the Royal Marsden is to offer chemoradiotherapy to advanced tumours only. So extramural spread of more than 5 millimetres, vascular invasion, and tumours that are threatening the TME plane. So this was a group of patients which made up about probably half of the patients we see in our MDTs. And we looked at those patients who we thought had had a good response. So they'd gone from a T3C or D to less than T3 involvement. And that bore out with a slightly better improvement from these patients compared with the ones that stayed as T3, T4. What we found was that in terms of the accuracy, MR showed reasonable agreement with pathology. But the whole point about any staging system is it's supposed to be predictive for ultimate outcomes. That's what staging is about. So whether something agrees with pathology is slightly less relevant to whether it actually predicts outcomes to a similar extent. And here we see the outcome data for the pathology stage tumours and the outcome data for the MR stage tumours. So this is the post-treatment MRI assessment. And you can see they're almost identical. In other words, we're probably just as likely to predict an outcome based on the final T stage as the pathologist is. So that's quite important in terms of conveying information to patients. So the factors associated with this tumour downstaging were the baseline age, sex, and size were not independent factors. Surprisingly, the baseline stage was not a factor, but that's probably because most of these tumours were advanced. But a tumor height of less than 5 centimeters and EMVI status positive at the outset were both risk factors. So a tumor height less than 5 centimeters, you were more likely to respond. You had a twofold increased chance of responding, whereas EMVI positive status, you had a threefold less chance of responding. But in some of our patients, induction chemotherapy was used, and when we did a separate analysis of this, there was a 9-fold increased chance of the tumor responding, i.e. going from EMVI positive to negative, if induction chemotherapy was used with the chemoradiotherapy. So the next sort of thing that we talk about is how we assess response. So you can do the T-staging, but you can also use tumor regression grading. And Stanley Yu in the next presentation is going to just cover how we've used this information and our outcomes from this. But really, it's essentially not taking into account the final T-stage, but looking at how much tumor has responded and been replaced by fibrosis. So in this particular case, there's no tumor signal left. It's all fibrosis, so that would be a good TRG response. If this hadn't changed very much, or if there was any small amounts of fibrosis, this would be a higher TRG grade. And what we've already found was that tumor regression grading relates to survival, and a poor tumor regression grade, you only have about a 27% survival. And this was from the Mercury study with multiple observers doing the tumor regression grading. And we find that it's an independent risk factor for both overall survival and disease-free survival. So in the end, when we look at the various methods of assessing response, like the height and the volume and the length of the tumor, it's really only the T-stage at the end of treatment on MR and the TRG that predict for pathology good response, but also show the best inter-observer agreement. So I'll skip this slide because Stanley is going to cover this in more detail. But the conclusion about TRG is that we think it's a prognostic and probably predictive biomarker. In other words, if you manage to get patients, a higher proportion of patients into this group, then it is likely that you get a better overall survival. It also is probably a more meaningful endpoint than PathCR, because we see many more patients with a TRG 1 and 2 than we do with PathCR. And these patients seem to do just as well as the PathCR patients in terms of outcomes. So what's intriguing is that we're occasionally seeing this effect after chemotherapy, and this is from the GEMCAD trial, which was run in Spain. And we, in the future, are going to be using, we are currently using TRG as a way of identifying patients for complete response. What we find with diffusion-weighted imaging and other techniques is that they don't really, we struggle to validate them because they don't really increase our ability to identify those patients. And even in this paper, which had stated that it did, when you look at the results, you actually see there's no difference in the confidence intervals for the area under the curve, the sensitivity or specificity. In other words, it hasn't really added. And what we're finding, certainly in our experience, is that the diffusion-weighted imaging unnecessarily rules out patients who are going into a complete response because of the huge false positive rate. So we use TRG, we use a clinical assessment, we don't tend to use biopsy. This is the sort of patient who we would offer preoperative chemoradiotherapy. The tumor is threatening the TME plane, and after treatment, you're just seeing dense fibrosis. Now, what we say here is whether or not the PET is positive, whether or not there's diffusion-weighted imaging restriction, we would still offer that patient a deferral of surgery approach. And here is an example of a tumor extending beyond the muscularis propria at baseline, and at the end of it, there's just fibrotic material left. Now, it could be that there's tumor cells present there, but what we don't know is the natural history of this. So what we do is we follow these patients and we keep an eye on the nature of that dense scar. And that, we think, is a much better way of identifying more and more patients who could successfully defer surgery. So this trial continues, the deferral surgery trial continues, and the point about this is we're testing the hypothesis that these tumor cells are non-viable. And these are our criteria. It's really TRG is the entry criteria for the study, and none of these features are exclusion criteria. The schedule involves digital rectal examination and quite frequent MRIs, but only 3 PET-CTs, because really you can't just keep irradiating patients with PET-CT in order to pick up a regrowth. And what we found was that we started this trial after visiting Brazil and hearing from Angelita. We put the trial protocol together. We used TRG, and that increased our accrual rate, but actually pro forma reporting increased it the most, because documenting these things consistently made the big difference. I think what I want to just talk about is where we're going with this information next. And the TRIGGER trial will be a prospective randomized trial, initially at feasibility and then phase 3, where patients will be randomized according to an MR-TRG strategy. So if they've had a good response at the end, they will be offered deferral. The control arm will be patients who will not have a TRG strategy at all, so they will just have the standard of care, which is, regardless of the MR response assessment, they would have surgery as is the standard of care throughout the world. But in this trial, patients who've had a good response will be offered deferral, and patients who've had a poor response will be given further consolidation chemotherapy prior to surgery. And the idea here is that we want to start using the TRG information to drive treatment for these patients. Thank you very much.